Right, good afternoon everyone. I think we'll make a start, and I'll go through some of the boring housekeeping stuff first anyway, so anybody coming on won't miss anything important. Good afternoon, welcome to our third Community Oncology webinar. Welcome to everybody who's come back, who's been to our previous 2 webinars, and welcome to anybody joining us for the first time this afternoon. I'm Charlotte Stevenson and I'm a Business Development Manager at Cardiff University. It's my role to sort of support these type of activities. A couple of quick housekeeping moments before we get started. We've got the chat function at the bottom if you want to talk to the team, if you've got any audio problems, you can't hear anything. We've got the Q&A there as well. If you've got any questions for the team and our fantastic speakers today, just pop them in there and one of the team will make sure they get answered during or after the webinar. We're all working in different locations this morning. We've already had some technical problems, so bear with us if anything goes awry, any interruptions from pets or children as well. And in order to continue this type of activity, we really need feedback from everybody who attends. So there'll be a link at the end and I'll be circulating that later this afternoon, and we'd really appreciate a few moments of your time to fill in that feedback. That's enough from me. I'm going to hand over to the Community Oncology team, Dr. Elise Lang. Enjoy.
Oh, thanks very much, Charlotte. Yeah, great to have you with us again. I'm Elise Lang. I'm a GP in Cardiff and also Macmillan GP lead for Velindre Cancer Centre. And we've got some great speakers today. So we've got Dr. Rachel Abbott, who's a dermatologist in a local hospital in University Hospital of Wales, and Dr. Vicky Fraser, who's an oncologist in Velindre Cancer Centre. I know Fiona's got some introductory slides she wants to do. Apologies, Fiona, I've just been caught in the hop. Did you want to do the poll today?
Would be great, Elise. Yes, thank you. Just before we start, I'm Fiona Rawlinson for people who haven't met me before. And the thing about virtual meetings is that we're not all kind of chatting with each other at coffee time. So we've just started each of the webinars just with a moment of who actually have we got on the call today. So Jess, hoping that technology is going to be kind to us, could you put the first poll up, please? And while they're doing that, just have a think, in your practice, wherever you're practicing, whatever your role is, what are the key things about diagnosing and managing skin cancers that you want to really learn about today? So the first question is, what is your main role? If you could let us know that, that would be fantastic. You will see I've put a comment in the chat already. I'm running the session 2 weeks today on sort of top tips for managing these situations, but particularly thinking around communication skills. And I'd be really glad if you would add anything that you really need me to cover, as it's more of an interactive workshop really for communication skills, but do please give us your thoughts. Right, so shall we see what people's main role is on the call today? Yes. So great. So far, and allowing for the fact that people may join us as they can, we've got GPs and trainees, nurse practitioners, people from palliative care teams, from nursing and from other medical backgrounds, and we may have more from an increasingly diverse setting. So that's wonderful, thank you. And there's one other question for us just to cover. It's really just thinking, where are you from? Obviously we're talking to you from Cardiff here, so process and things may be NHS Wales dependent, but just think where you are if you're not from Cardiff, and forgive us the blanket term of somewhere else. Everybody is very welcome wherever you are, but just think where you are working. Some of the processes might be a little bit different, and perhaps today we'll facilitate you to go and seek out what the local processes are in your area if you're not sure. So that's wonderful. So where have we got people from? So majority from Wales, some from England, and as in our previous webinars, somewhere else is there. So from somewhere else, please could you put where you're from in the chat? That would be absolutely wonderful, but everybody is very welcome. And as Charlotte said, we've got a formal question and answer place for you to put your questions to the speakers as we go through. but we will also be keeping an eye on the chat button. So if you've got anything that you want to ask, then we will pick it up as we go through the session. I'm going to hand over to you, Elise, now. So thank you very much, all. I hope you enjoyed the session.
Great. Well, yeah. Welcome again, everybody, and lovely to see where people are from and their roles, because it does help us sort of think about how we're going to do the next one. So these stemmed from full day courses that we ran once successfully and attempted to run in March last year. But obviously that was curtailed because of COVID. So some of you may have heard Ricky speak at that one previously, but also we'd just like to talk about, from a primary care point of view, how we diagnose and manage skin cancers. So our first speaker today is Dr. Rachel Abbott, who, as I say, is a consultant dermatologist in the Heath Hospital. Good afternoon, Rachel.
Good afternoon.
Hi, lovely to have you with us. I mean, I guess from a primary care point of view, things have changed hugely in the last year, haven't they? And, you know, we're seeing a very different job than we did a year ago. So from our point of view, how are things looking in the hospital? What are dermatology referrals looking like in terms of USCs and things like that in the Heath currently?
Okay, so firstly, a big thank you to all GPs for flexibility and working with us and being patient. I think it might be helpful to have the first slide up, actually, because that sort of demonstrates the situation quite nicely. Oh, sorry, that the first slide was just to say that I'm unpaid ambassadors for the British Skin Foundation and the Skin Cancer Charity. So just declaring my conflicts of interest, but they're unpaid roles, so I've got no financial interest, just passionate about skin cancer prevention. And so this was really, so I couldn't resist adding in a quick slide or two about where we are in terms of skin cancer incidence. And although this is just melanoma, this quite nicely highlights the kind of areas where we most commonly see skin cancers. It sort of reflects all skin cancer, even though it's focused on melanoma across England and Wales. And so you'll see South East Wales highlights quite well there. There are some other pockets, and then some other areas in England, because I'm aware there's some people dialing in from England today. So it's estimated that about 250,000, that's probably a conservative estimate, of skin cancers are excised in the UK each year, which is a phenomenal number. So even when we have a small break in service, or we're only able to see 95% rather than 100% of the patients that we normally see, that has a huge impact on our numbers, unfortunately. Would you mind just moving on to the next slide, please? Thanks. And this is just to demonstrate, so this is Welsh data for melanoma, just demonstrating all the health boards and the increase that we're seeing in melanoma. And this is reflected in basal cell cancer and squamous cell cancer as well, which are the three commonest types of skin cancer. I'm sure you know all this, but it's just really to kind of sound our trumpet that we've got a big problem with skin cancer. Obviously, we know that the majority of skin cancers are due to sun exposure, and we've now got cohorts of patients who have been going abroad regularly for holidays and having huge amounts of UV exposure. Obviously, combined with the fact that decades ago there wasn't really much known about the association between the sun and skin cancer. And our sort of baby boomer cohort are now hitting their 70s, and we're just seeing skin cancer rates go up and up, particularly amongst squamous cell cancers, which we'll come back to later, because they've been a bit of a silent epidemic. Could you move on to the next slide, please? Thank you. So sorry, to go back to your question, Elise. So as you can see, we were sort of bouncing along the 7,000 dermatology referrals. We think this is an underestimate, because we processed 17,000 in Cardiff and Vale alone. But if you just follow the graphic, and then obviously we hit April last year, and there was a massive drop in referrals. And this slide only goes up to July. Sorry, that was the latest data I could get my hands on easily. And when I last heard, we're operating about 20% below, having had subsequent dips with each lockdown on referrals, and then they bounce back up again after a lockdown. So although in Cardiff and I believe in other dermatology centres we've managed to keep open, we are operating at about 70% capacity with our new patient appointments at the moment, which is having a huge knock-on effect to our waiting lists, I'm sure you're all familiar with. So if you go on to the next slide, please. So what we're aiming to do is to see all suspected melanomas or SCCs or other invasive skin cancers within 6 weeks with a standard USC appointment, and then head and neck BCCs or atypical nevi, which might be suspicious, within 3 months as an urgent appointment. Unfortunately, as you'll appreciate, we're not hitting these targets at the moment. And then low risk BCCs on the trunk or limbs within 36 weeks, or you've probably noticed that we are asking if you're able to excise these in primary care as per the NICE skin cancer guidance. And we are across Wales, and I'm sure there's similar schemes in England where as a dermatology community, we're very keen to support any GPs who are interested in this and or who feel they might benefit from further training. You're certainly welcome to join us in Cardiff anytime, where we do a lot of skin cancer surgery. My email address will be at the end of this presentation. And then in some areas of Wales prior to the pandemic, there was a bit of a grey area around benign lesions, particularly those that were deemed symptomatic. However, we're not able to see these currently at the moment at all. As I'm sure you're aware, we've got major limitations on our outpatient appointments. We've had staff redeployed to other areas. The big problem with our waiting area, because normally it's standing room only, and as I'm sure you're experiencing the similar experience, that we've now got to socially distance. That limits the amount of patients we can see at any one time. We are trialling virtual appointments. We have been since the pandemic hit. However, the median age of our skin cancer population is 75. I come into work every day and feel very young. It's wonderful. And so we do know that access to the internet is a problem for this age group. There's also issues with consenting for more complex surgery, particularly on the head and neck, particularly if there might be nerve impairment afterwards, and then hearing impairment when using telephone appointments can be really difficult for some of our patients as well. So we're trying. And if you've got any suggestions, or if you know of anything that's worked elsewhere, please let us know. Could you move on to the next slide, please? So this is the reality. Again, apologies, this is only up till October last year, but it'll only be worse now. So you can see every health board, so dermatology is represented in blue, and all health boards are struggling with dermatology referrals, apart from Paris, which doesn't have a dermatology department. So that tells you everything you need to know about that, probably. So some of the things we've been piloting, which those of you in Newport and Cardiff might have come across, is Teledemoscopy for suspected benign lesions. So often we'll be referred in a lesion, and we'll think it's probably benign, but we'd just like to check it with a demoscopy image, which pre-COVID would have done as an appointment, particularly in Cardiff, where we've got quite a small geographic area. In Newport, they'd been trialling a teledemoscopy at centres across Newport, photography hubs, for some time successfully. So in Cardiff, because Medical Illustration have got far more appointments available face-to-face than we have, so we've been offering this to patients, and then we've been able to check them virtually, and then we've managed to, from our pilot, we've managed to deal with 95% of these patients without them needing a further appointment. So we're just trying to work out how logistically we can continue with this, because it's obviously quite time consuming for patients to travel, but then not to see us, and with all the paperwork behind the scenes. So we're thinking about setting up medical illustration hubs, perhaps at Barry Hospital and larger GP practices, if you'd be interested in the future, with a view to taking this as a positive step to treating people nearer to home, and reducing the impact on the environment of people travelling to hospital. We're also at the moment using telephone appointments for follow-up patients where appropriate, within the limitations I mentioned earlier. And we have found video appointments for patients with inflammatory skin disease, particularly our younger population with acne, for example, very useful. So that's kind of where we are at the moment. Over to you, Louise.
It's a great overview and position. Obviously, it looks hugely difficult to manage. In terms of teledemoscopy appointments, then, if a patient would head to Medical Illustration and have a picture taken there under a dermatoscope, is it? And then you can look at the image.
Exactly. Yeah. It's unfortunately behind the scenes, it looks great because it all comes in electronic referral, but then everything after that is done on paper. that's the bit that we're trying to change in Cardiff anyway. And Newport have got an established Teledemoscopy service, which is fantastic. I believe that Cumtaf have got a lesion photography service, and I think Swansea have got some sort of hybrid service between teledermatology like we've got in Cardiff and the demoscopy service. And there are plans to set this up in West Wales as well to support the community there, because unfortunately there's no actual consultant dermatologist in West Wales at the moment. But the idea is that Haldar could be supported virtually by dermatologists across Wales, but that's something that's in progress currently.
Yeah, thank you. And I guess I hadn't realised that was there, because a lot of our images now actually come in remotely to us, and we aren't seeing as many patients face to face as we would have done. So if a patient sends us an image and we can send it on then in Cardiff for telederm opinion, is there any advice about how to get a better quality image, or what we should be telling the patient to do?
Yes, if you go on to my next slide, one of my colleagues, Richard Motley, who those of you who work in Cardiff will know well, has produced in conjunction with medical illustration these leaflets advising either in a clinical setting taking photographs on a smartphone, or for patients taking photos on a smartphone. So I'm going to email these to you after this talk, and then hopefully you'll be able to distribute them to people who are attending today. And I think that's probably rather than talk through them.
No, there's too much detail to kind of look at, isn't it? But something like that to be shared and to have in our offices would be hugely helpful.
And essentially, as long as the picture's clear enough, if it's an obvious squamous cell cancer or melanoma, then you don't need to worry too much on detail. It's these benign probable lesions that we're struggling with, and that's why the demoscopy, in addition to the clinical photographs, has been so helpful, because it just gives you that extra information.
Thank you. And I guess, leading on from that, I guess, what's your advice to manage patients as best we can? I think I said to you before, the last melanoma I spotted was in an opportunistic blood pressure check when the man had to take his jumper off and I could see something odd on his side. We're not seeing patients as much as we used to. Is there any advice and tips to pass on to patients, particularly say people who've had melanomas or skin cancers before, in terms of what they should be doing for themselves in terms of skin checks and
That's
the like?
great. Yeah, if you move on to my next slide, please. So obviously we know this, we're all familiar with the risk factors for skin cancer. So as you mentioned, previous skin cancer, patients on immunosuppression, hopefully any patient who's had skin cancer and is on immunosuppression will be part of our follow-up cycle anyway. Skin phototype, hair and eye colour, moles and freckles, family history, genetic factors, occupation. So farmers, I suppose, particularly in Wales, and outdoor hobbies. So I see a lot of golfers in my clinic. So these are the sort of demographic risk factors. And then if you move on to the next slide, please. But then looking at the individual, this is a slide for Cancer Research UK showing a number of new melanoma cases. And so the rates are the lines, and then the cases are the columns. And you'll notice that what we're seeing is a huge increase in melanomas in older men. That's why that blue line is sort of disappearing up into the top right hand corner. So these are the patients at an individual level that we really want to see. So we know that men, particularly older men, present later as well at higher stage disease, and we really want to see these people. So it's really difficult because women are better at examining their skin, which obviously we really encourage people to take ownership of their skin, get to know their skin, and examine it at least once a month for any changes, but unfortunately, it's men. For example, in that situation you just mentioned, where often the commonest site for melanoma for men is on the back, and they can't see you can't see your own backs, and so often it is an opportunistic spot. Whereas men, for women, the commonest site is on the lower leg, which is easier for them to pick up. But the majority of cancers are picked up. I know we always remember the ones that we picked up, but the majority of skin cancers are picked up by patients or their relatives themselves. And we start seeing more as we go into the summer, and people start taking off their clothes more for, and get together for family events, for barbecues and things. And I think that's when a lot of skin cancers get spotted. But it is really difficult. I suppose examining an older man's back would probably be the most useful advice I can give if you've got the opportunity.
Yeah, I mean, that's helpful in itself, though, isn't it? Because I think, as we said on previous webinars, things like taking someone's weight in the few chances we do see them is helpful for, say, a rapid referral for bowel cancer. So if we have got someone in the room and we're doing a chest examination or, you know, an abdominal examination, you know, if we can take that moment, particularly with an elderly or older male, but also, you know, anyone, just to look at the back, that's a really valid point. I think that's a useful take-home point. Thank you.
Great. If you move on to my next slide, I think I've just got a couple of slides just highlighting particular red flag issues. So obviously, if there's bleeding, and that's if it's bleeding related to an irritated mole, that's usually quite reassuring. But if it's bleeding because there's ulceration, then that suggests that it's quite likely to be a tumour and it's outgrowing its blood supply. A great way of distinguishing when you see a man who's lost his hair and has lots of scaly bits on his scalp, a great way for distinguishing between sun damage and squamous cell cancers is whether there's pain or not. It's a really sensitive symptom for picking up squamous cell cancers, especially in these older men who have multiple boinoid actinic keratoses. And then also just thinking about nails, we know that skin cancers are much less common in people with more pigment in their skin. However, they do still develop skin cancers on the acral sites particularly, and it's thought to be a mechanism probably due to trauma rather than due to sun damage. However, unfortunately, we also know that people with more pigment in their skin tend to present later with skin cancer. So if someone has got particularly evidence of nail destruction in association with changes in pigment, then that's just another red flag sign as well.
Rachel, just picking up on the comment about pain with a squamous cell carcinoma, is that pain to touch? Is it something we should be doing during an examination, or is it what the patient would report?
They would usually report it. I mean, it's quite common for any protruding lesion to be tender when touched, but if they're saying it's painful, it's uncomfortable without any provocation, then that's a red flag sign.
Excellent, thank you. So I know in terms of other sort of red flag signs, you were sort of trying to give us some pointers in terms of when to worry and what to look for, isn't it, for melanomas?
Yeah, so obviously we're all familiar with the sort of ABCD mnemonic and then evolution being for change, and it's really change that's the key factor. And change in a pigmented lesion on the back, particularly in a man, would be a red flag sign. However, it's quite common for as moles mature in younger people, they become more raised, and so yes, that's a change, but it's the normal maturation of an intradermal nevus. So we often get quite a few referrals saying, oh, the moles become more raised, and as soon as I look at the age, and I know before I look at the photo that it's most likely to be an intradermal nevus, which so it's just I suppose it's just trying to maybe sort of hint that I guess change doesn't always necessarily mean that it's cancerous. I'm sure this is something that you're all familiar with, but often younger people whose moles are maturing can be reassured. It's easy, obviously. I appreciate I've got the Dermoscopy, so I can check that it's got a nice regular pigment underneath, so it's much easier for me. So I do appreciate that.
It's certainly helpful to know, isn't it? And I think your next few slides just talk through some of the immortality data, I think, don't they, for the
yeah, so this is quite striking. This is unpublished data that was kindly shared by Wixie. It's in the process of being published, which is very exciting. And it demonstrates that the problem we're seeing. So the top line is the top three lines are melanomas in men, women, and then all persons, and then the dotted lines are squamous cell cancers. So you'll see that, so this goes from 2008, 2010, and then the most recent data is the 2015 to 2017 data. And you can see that it's now more, so men with squamous cell cancers, because it's very rare, obviously, for men to die of basal cell cancer, so this is what we think it's due to, more likely to die than women with melanoma. So although in the past there's been a huge focus on melanoma, we now know that actually it's men with squamous cell cancer that we really need to focus on, and Rick will be talking about this a little bit later as well. So the problem is that these SCCs often happen in what we call our silent generation of very elderly men who don't tend to publicize or really sort of talk about these things, and so this sort of epidemic of squamous cell cancer is just not really being heard, but hopefully with this publication it'll become more apparent. Sorry, can you move on to the next slide? Sorry, Elise.
I guess highlighting that is the bit which I know your next slide is about, how we can help patients present sooner, isn't it? Really, what's out there to support them, particularly that elderly person, or someone who has something under a hat, or
I know,
somewhere well hidden.
We all see them from time to time, and yes, and it's people, understandable. People worry about. They often say, "Oh, I knew there was something wrong, and I just didn't want to address it." And it'd be interesting to do some psychological studies looking into the reasons behind that in more detail. But really the key message is about patient education and empowerment. And Skin, one of the charities I work with, are really great about supporting this through social media campaigns, because there's no public funding for skin cancer prevention. And also there are some apps. So there's My Skin. I've got no financial interest in these. I just think they're quite a good idea. So they're apps for monitoring skin. And that's an important distinction between apps. That there's a lot of apps on the market who are offering to diagnose skin cancers. And although AI is a really exciting area, and I personally think we should bring it on, quite frankly, but it's not there yet in terms of its diagnostic ability. And a lot of the apps still involve humans sat there at the end of the day distinguishing between the benign and the obviously malignant, because it turns out humans actually have got skills beyond AI which are particularly helpful in diagnosing skin cancers. So the two apps, so there's My Skin, which is in the NHS apps library, and then there's which is free for the basic version. And the nice thing about it is that patients can take pictures and they can try it out for free. And if they like it, then they can pay for the upgrade, which I think is about £15 a year. And you can take photos of your moles. They're stored in the app, so you don't have to then sort of scroll through the thousands of photos that we all have on our phones. And you can also set up reminders as well through the app. And then My Skin Selfie was developed by Newcastle University, and it's more for all skin conditions, but you can use it for mole mapping as well. And so that's another option that's CE marked and MHRA registered. But at the moment, we don't recommend any diagnostic apps because they're not accurate enough presently. I'm sure they will be at some point in the future, but we're not quite there yet.
Fabulous. And I'm just aware that Richard will be chomping at the bit to get on his section. So I know you just wanted to do a little bit of highlighting about sort of skin risk in South Wales, didn't you?
Yes. So yeah, we'll all be familiar with our patients in South Wales. I mean, I haven't proven this yet, but I have a theory that being brought up on Barry Island is an independent risk factor for developing skin cancer. We did do a survey a few years ago about sun safety and skin cancer in Wales, and this was through Healthwise Wales, and we had a response rate of 6,000, or just under 6,500 people. Unfortunately, tanning is still associated with health and attractiveness by the majority of people. Well, 2/3 of the youngest cohort, 16 to 24-year-olds, reported sunburn within the last year. So our sort of skin cancer prevention messages really aren't hitting home, unfortunately. And then just under 2/3 of people only use sun protection measures whilst they're abroad. They don't tend to use them in the UK. And we know that they do tend to rely on sunscreen. I mean, I have a lot of patients coming back after the summer holidays and say, "Oh, don't worry, doctor. Yes, I went on and I had my lovely sunny holiday laying in the sun for a week, but I put my sunscreen on and I just sort of put my head in my hands and think, oh my goodness, where do I start?" And then there is confusion around vitamin D. Some people think they need to sunbathe to get vitamin D. Other people don't think that there's any relationship with vitamin D and the sun. Obviously, it's been in the press quite a lot because of the possible associations or benefits with COVID. But we do recognise that it's important for people to get vitamin D during the summer months when the UVB levels enable us to make it. It is recommended that everyone takes vitamin D supplements to maintain their levels over the winter months. And for our patients who never go in the sun after a skin cancer diagnosis, we do recommend they take it all year round. And you've probably noticed that with our patients with melanomas, it is in the guidelines to check their vitamin D levels at diagnosis, because there was concern about the majority of patients with melanoma noting to have low vitamin D levels, and whether this had some influence on the immune system. But the evidence level for this is actually quite low. Sorry, I think as I mentioned, there's no funding from the UK government for skin cancer prevention, even though 90% is estimated to be preventable. There are some national campaigns run by charities, regional campaigns with relation to with regards to Wales, so Public Health Wales, Skincare Cymru and Tenevis. And then with our local health boards, this is a photo of me and my team pre-COVID, promoting sun safety and skin cancer awareness, which we do during Sun Awareness Week. And those are my contact details. And thank you very much. And please let me know if you've got any questions. And then it's my turn to question Ricky, I believe.
Thanks very much, Rachel.
Okay, Ricky. So just to let you know, I agreed to talk today because you're always so kind at agreeing to talk at our skin cancer meetings. So I hope you're going to tell us about how the landscape has changed from melanoma treatment for patients who've got stage 3 and 4 disease. Ricky, are you there?
We can't hear you, Ricky. Are you on mute? Do you want to unmute? Not on mute? No. We couldn't see Ricky just before the start of the webinar. Now we can see him, but we actually can't hear him.
Perhaps while we're just sorting the questions out, can I take one of the questions from the chat, Rachel, which is just about numbers, and just Karen's asking, how do UK skin cancer incidence compare to Europe rates?
Okay. Yes, so we've started now collecting accurate data on all skin cancers. Previously, it was just deemed too difficult because of the numbers to collect accurate data on squamous cell cancer and basal cell cancer. So it's really exciting that there were changes made in 2013, where now the data is collected directly from pathology reports. So I did mention these publications that are coming out this year. So hopefully that will enable us to compare BCCs and SCCs. Interestingly, the further north you go in Europe, the higher the rates get. So Scandinavia in particular has got very high rates of melanoma, which is comparable because countries are pretty good at collecting data on melanoma. We're not sure whether this is because the Scandinavian countries are so good at collecting data, or whether it is a true higher incidence rate. There's probably both factors. So it does seem to be that those countries that are deprived of sunshine all year round, or only have a limited window of summer, have the highest incidence of particularly of melanoma, which we know is due to high to exposure, probably when we go on holiday and have an intense burst of UV light, as opposed to basal cell cancers, which are more thought to be more due to chronic sun exposure. But the whole of Western Europe really has a problem with skin cancer.
Thank you. No, that's really interesting. I'm sure that answers.
Fiona, can you hear me now?
Yes, we can.
Yes.
Great. Okay.
Wonderful.
Sorry, Ricky. So I was just saying, do you want to tell us, please, about how the landscape of treatment has changed for melanoma stage 3 and 4, please?
Yeah, no, will do. Rachel, slightly worryingly, I think I'm in that picture on Barry Island Beach that you showed, which is a slight concern. But yeah, next slide. Next slide. So I guess the important thing to know about melanoma is things have changed really quickly. So, you know, just 7 or 8 years ago, this was the common landscape for stage 4 melanoma. So melanoma, it spread to other organs, brain, liver, lungs, etc. And about 5% of patients were alive at 5 years. So, you know, there was one chemotherapy drug, it was dacarbazine, it was rubbish, it didn't really do very much. And most patients died pretty quickly from being diagnosed, as many of you unfortunately will know. Next slide. But this is where we are now. So there's only ever about 3 things worth taking from any talk I do. So this is probably point number 1 worth remembering. And this is now with the immunotherapies and targeted therapies we've got available for melanoma. more than 50% of patients with stage 4 metastatic disease, where it's spread to the liver or to the lungs or even to the brain, are now alive at 5 years. And the vast majority of those patients will have stopped treatment at 2 years, so they'll be treatment free, and a number of them will be disease free. And so that's a real paradigm shift in the way we view melanoma and indeed other cancers. You know, we're talking about stage 4 disease, spread disease, and we're talking in melanoma of more than half of them being alive at 5 years. And so, you know, that really changes the conversation we're having around melanoma. Next slide. And so what's happened? How have we got to this point? And so there's been really two massive advances over the last few years. One is immunotherapy, and anyone who knows me will know that I love to speak about immunotherapy, and I'll talk a little bit about that over the coming slides. And then the second thing is these targeted therapies. And we know that in melanoma, about 40 to 45% of patients will have a mutation in a protein called BRAF, doesn't matter what it's called, it's just a protein. And that mutation will be driving that melanoma. And so we know if you treat that BRAF with a tablet treatment that blocks that protein, that will stop the cancer growing and often within a few days cause complete regression of that tumor. Now that won't be everlasting, and most people will then start to progress around about a year down the line, although about 20% will get to 5 years without progressing. But again, that's a real paradigm shift. We've got immunotherapy with these durable responses and potentially curing patients, and I use that word you know, with care, potentially curing patients with stage 4 metastatic disease. And we've got these BRAF inhibitors, a tablet treatment, which is, you know, this mutation's present in just under half of patients. And in those patients, these patients can have a really rapid response where a patient can be moribund and dying, and just a few days down the line can really turn around and be very fit and well. And so this isn't every patient and this isn't every tumor type, but in melanoma, we're lucky that we've got a group of patients that we can treat with that drug. Next slide. So just to keep it really simple, is in the stage 4 landscape, so in metastatic disease, we've got chemotherapy in the background and we still use it, but response rates are poor. But we've got combination immunotherapy with excellent survival rates, more than 50% at 5 years. We've got single agent immunotherapy, less toxic, survival rate of 5 years, about 45%. And then we've got these tablet treatments, these BRAF inhibitors, which again, these patients get these rapid, deep, fast responses. And in terms of way to remember this, anything that's got AB or MAB on the end of it is an IV treatment. And anything that's got IB on the end of it, so dabrafenib, which is the drug that I use, or encorafenib, are oral tablet treatments. Next slide. And then I guess just to say very quickly about stage 3 disease, which has also had a bit of a change in its landscape. So stage 3 cancer is where it's spread locally. So either it's a very deep tumor, and we've done a sentinel lymph node and the sentinel lymph node was involved, or when they present, they've got lymph nodes involved up front. And so those patients, when we do surgery, in theory, potentially they're cured from their melanoma, but we know those with the highest stage 3 disease have a really high chance of it coming back. And so now you'll have patients who are on adjuvant therapy, adjuvant being an add-on therapy, for 1 year that reduces the chances of the melanoma coming back by about 50%. And for stage 3 disease, we either give a year of immunotherapy or we give a year of the tablet therapy. Rachel, any questions?
There's no questions in the Q&A. Thanks, Ricky. It's fantastic. These drugs are available for melanoma. Do you want to tell us about the exciting developments in SCC now, please?
Yeah, no problem. So next slide. Next slide. So, I'm going to keep this relatively brief. I've just got 2 or 3 slides on it. But as Rachel, showed the picture and described, squamous cell carcinoma for a long time has been a bit forgotten about. So, these patients have, if you can remove it, that's fantastic. But the patients who've got a locally advanced disease, so it's growing locally and can't be resected, or who get metastatic disease, up till now we have very little options for them. As Rachel explained, they're often immunosuppressed, they're often elderly patients, and so the only treatment option we had available was chemotherapy, which, as you can imagine, with that older age group, quite a frail group, it was very difficult to treat. And so from diagnosis to death in locally advanced or metastatic squamous cell carcinoma, it was around a year at best. And so that was a pretty poor outcome. You know, we used to give some of them chemotherapy. No one did particularly well with the chemotherapy. And even if it responded, it tended to progress quite quickly. Next slide. And I guess locally advanced squamous cell probably doesn't get the same airtime that a lot of cancers have. But for patients, it can be really, really distressing. And in primary care, you'll know this better than I do. You know, often they're really unsightly. They're often in the head and neck regions. You know, and for a patient, they can be really distressing if they can't be removed or if radiotherapy isn't of benefit. Next slide. And so I just wanted to mention that we've now got a new treatment that we've got licensed for locally advanced unresectable disease or metastatic squamous cell carcinoma. Again, no surprises, it's an immunotherapy drug that we give every 3 weeks. It's called cemiplimab. And again, I'm not going to bore you with data because no one likes data except oncologists. But the bottom line is that a lot more patients are now surviving. And actually this survival curve is sitting at around 70%, even when we're getting out to 3 or 4 years. So again, a real paradigm shift in the option we've got available for locally advanced unresectable or squamous cell carcinoma of the skin. Next slide.
Thanks, Ricky. Still no questions, we'd be glad to hear.
Okay.
So it's fantastic news at an individual level for these patients who, you know, even 7 or 8 years ago, we had nothing to offer really. But just to put it in context, could you just give us a ballpark figure for how much these treatments cost before we move on to immunotherapy?
Yeah, you can do. It'll take the shine off my talk.
I know. I'm sorry. I used to think the plastic surgeons were the expensive part of our skin cancer pathway, but
yeah. So you know, the actual figures that we pay, you know, in terms of NICE aren't really disclosed. It's thought to be for the combination treatment, which is 4 treatments. It's somewhere in the range of 60 to 80,000 pounds. So you know, these are by no means cheap. I absolutely take that on board, and that's why, you know, there are difficult decisions to make based on patient fitness. And so there are still patients who, despite having these options available, we decide not to treat because they're too frail. So, you know, we don't decide based on finance, but we do need to, you know, consider the whole NHS when we're making these calls.
Yeah, absolutely. Thanks. So did you want to tell us a bit more about immunotherapy, please?
I will, and I'm going to try and do it in about 6 or 7 minutes. So some of you will have heard about immunotherapy and some of you may not have, but this isn't going away. So immunotherapy is now being used across lots of different tumor sites. And in fact, in melanoma, in squamous cell, Merkel's that I treat, and in kidney cancer, I probably treat 1 in 50 of my patients with traditional chemotherapy. The vast majority of what I do now is immunotherapy, and if I'm not giving immunotherapy, I'm giving targeted therapies. So, you know, chemotherapy still has a role, but you're going to see less and less of it across different tumor sites. And so how does immunotherapy work? And I'm sorry to go back to sort of cell biology stuff. I promise to keep this brief. You know, this works by stimulating your own immune system to fight the cancer. And patients intrinsically like that concept. They hate the idea that I'm poisoning them, in inverted commas, with chemotherapy. They much rather the idea that I'm harvesting their own immune system to fight the cancer. And that's in essence what we're doing. So these immunotherapies are just taking your own normal immune system that can fight cancer, but just isn't very good at it, and make it better. And there's a couple of things you may have learned about renal cancer, kidney cancer when you're at medical school. One was that we had cannonball metastases, those classic cannonballs. And secondly, that sometimes kidney cancer patients their disease can just disappear without us doing anything. And that's because of the immune system. Next slide. So just to say, there's different ways the immune system can work. And so vaccines is pretty much all anyone talks about at the moment. And so it would make sense that we could use cancer vaccines and give the body a little bit of a cancer antigen, and we'd make an immune response, and that would fight the cancer. But it just doesn't seem to work, and we don't really know why. Cytokines, so cyto meaning cell, kine meaning attract. Cytokines are things like interleukins that your body produces, again, that stimulate an immune response. And there has been some success using things like interleukin-2 in cancer, but again, it hasn't really come to fruition as a widespread treatment because of the side effects. Next slide. So as I said, there's only 2 or 3 things worth taking from any talk I do. This is number 2, and this is how they work. And again, keeping this really simple, you've got T cells, and you'll remember that you've got CD4 and CD8 T cells that are in your body and go around and try and kill bacteria and viruses. And they also try and kill tumor cells. But the tumor cells aren't a big fan of being killed. It's not on their to-do list of life. And so they put a little protein on the surface called PDL1. Doesn't matter what it's called. It just stands for programmed death ligand 1. Doesn't matter what it's called. It's just a protein. And that protein binds to a receptor on the T cell called PD1, programmed death 1. Doesn't matter what it's called. But when those 2 proteins bind together, it acts as a brake on the immune system. And so what these antibodies are, what this immunotherapy is that I keep talking about, they're antibodies that either bind to PD1 or PDL1, remove that brake, upregulate the T cell, and allow the T cell to kill the tumor cell. And so that's what these checkpoint inhibitors or immunotherapy refer to. And it's now being used across lots of different tumor sites. So I use it in melanoma and in kidney cancer. Mick will be using it for lots of his lung cancer patients. We use it for head and neck cancer patients, both as frontline treatments. It's now frontline treatment in bladder cancer. It's frontline treatment in squamous cell, in Merkel cell, which is a type of rare skin tumor, in different types of hematological tumors, some types of bowel cancers, even some types of triple negative breast cancer. So these treatments are now being used widespread across tumor types, and barely a week goes by without a new license across a different tumor type. Next slide.
Thanks, Ricky. So that's the good news. Do you want to tell us the not so good news?
Yeah. And so this is the bit that, again, this is point 3 to take from my talk today, which are the side effects that you need to know about in primary care. And this really is important because these patients will present to you with, non-specific symptoms of fatigue or diarrhea or headache. And it's very easy for you to think, well, a little bit of loperamide and some diaurolite will sort this diarrhea out. It won't. And we've had a couple of really difficult cases I've looked after that I take absolutely responsibility for, that weren't managed well enough, that bounce between secondary care and primary care with diarrhea, treated with loperamide, treated with codeine. The diarrhea didn't resolve and they ended up having a colectomy. So again, that's my responsibility. I should be doing more education, but hopefully if you take nothing else, take that we have these side effects, that they're autoimmune in nature, and I'm going to tell you how we manage them in a second. Next slide. So whenever I see a patient in new patient clinic, this is what I say to them. If you can name me an organ and put itis on the end of it, I've probably seen that side effect, and that side effect could happen to you. So you can get colitis, so inflammation of the bowel. You can get hepatitis, so inflammation of the liver. You can get a whole host of endocrinopathies. Again, this is really where primary care, you may see some of these. So hypothyroidism presents in about 10% of patients. Hypoadrenalism presenting as low sodium, high potassium. Postural hypotension, fatigue, occurs in about 3 or 4% of patients. Pneumonitis, so shortness of breath, can present with irritation of the lung tissue. Nephritis, but if you can name an organ, we can see an itis of it. And so it's really important that we keep a really wide thought process when we're thinking about these toxicities. Next slide. I'm not going to go into lots of complicated stuff on other toxicities because you don't need to know that. But I guess the point is that if a patient's on immunotherapy, and I think some of the work that I'm trying to do with GPs is looking at, can we do some sort of immunotherapy flags? If a patient's on immunotherapy and they present to you with a symptom you don't really understand or you can't really put together, it's probably related to the immunotherapy, and steroids of some description is probably the answer. And if it's a moderate toxicity, oral steroids is very reasonable. If it's a nasty toxicity, IV steroids is normally what we would do. And no one would ever criticize 1 milligram per kilogram of methylprednisolone IV as an inpatient. Okay, so in GP world, the things that you really don't want to miss are the diarrhea from immunotherapy, because these patients can die really quickly from their colitis. And also the shortness of breath on immunotherapy, again, is pneumonitis until proven otherwise, and all these endocrinopathies. Next slide.
Sorry, just quickly. In primary care, how long, after they're on immunotherapy, should we be worried about that?
Yeah, great question, Elise. So any time up to about 18 months after they've finished immunotherapy, we need to think about immunotherapy toxicities. So most will occur when the patient's on it. The vast majority will occur within about 6 months of finishing treatment, but it still can happen up to 2 years later. And I've had several patients develop colitis from immunotherapy a long time after having finished it. Just a couple of things that are out there. So the Velindre app is out there that's got the immunotherapy guidelines. It's free to download. I'm not getting money out of promoting it. And it's also got other guidelines around hypercalcemia, cord compression, etc. And then again, patients, and I know patients suck at normally carrying around information, but they're often really good at carrying around their immunotherapy alert cards. And on that alert card, there is a QR code that if you scan, it will bring up the immunotherapy guidelines. So that can be quite useful. Next slide. So I guess just some really, simple do's and don'ts. Do think about immunotherapy toxicity, as Elise rightly pointed out, even if the treatment is finished. In someone presenting to general practice generally tired on immunotherapy or had immunotherapy, always check the thyroid and try and do a 9 AM cortisol. And please, 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 please don't give loperamide or codeine to a patient who's on immunotherapy who's got diarrhea. It will bung them up, absolutely, but it will do nothing to help the colitis. Next slide. So I'll stop there. I guess, look, I think immunotherapy is here to stay. I'm really keen to work on building more education, particularly for primary care. It's a real passion of mine. So very happy to hear from anyone who either wants some teaching within their GP practices or have got any ideas. I know Elise is going to send out a link for a talk that we're giving in a couple of weeks' time. And feel free to drop me an email.
Thanks, Ricky.
Yeah, thank you. I'm sure Fiona's going to come in with some questions now as well. But I guess, from a primary care point of view, that sort of delay, particularly on the immunotherapy toxicity potential, just comes back to our coding when we get your letters in saying they're on immunotherapy, and please can primary care just pick up and flag in the notes, whether it's a yellow box that says immunotherapy commenced, 10th of March 2021, be aware of side effects. But once that letter's gone in and dropped off the sort of front page of our notes, it could easily be forgotten about. Fiona, do you want to come in?
Yes, so one question from Rachel, and I don't know if anybody on the Velindre site can put anything in the chat. What's the name of the Velindre app to search for it? Rachel,
So you just put Velindre Acute Oncology app.
Acute Oncology app.
Yeah.
And we'll hear a little bit more about that next week. Thank you. And then Toby's, presumably we should be discussing with Oncology if we're concerned not starting oral steroids in primary care. What are your thoughts on that?
Yeah, no, that's a really good question. So I think if someone's on immunotherapy and you're worried, I think you should speak to Oncology. These patients are really easy, still deteriorate really quickly. I lost a patient just a couple of nights ago from a pneumonitis who ended up on ITU but didn't survive. So I think if you're worried about a patient who's on immunotherapy, I think it's worth speaking to someone from the oncology team. And if someone's just generally, a bit tired, the endocrine things are the things to think about as a starter for 10. They're really easy to miss, hypothyroidism, hypoadrenalism. I don't want to get into it today, but there's something called hypophysitis, which is inflammation of the pituitary gland, and that can knock out all the hormones. So.
No, that's great. Thank you. Any other questions, folks? We've been extremely efficient with time, so fantastic for Rachel and Ricky. Thank you so much. We are looking for the app, and the general answer for everybody is that we will try and email the link out for people.
I was going to ask Ricky, I know in primary care you've publicised the use of the UCONS tool for treatment toxicity. Can we apply that in immunotherapy settings, Ricky, or is it written for chemo?
So yeah, there is a specific immunotherapy UCONS tool available, which again we could post that link out, and it gives really straightforward.
So obviously we're hopefully familiar with our skin cancer cohort, but when they're on immunotherapy for other non-skin conditions, then it's great now that we've got access to Velindre notes. So that's really helped. But
and the challenge, team, I have to be honest, the challenge going forward is there's lots of patients now who are on a combination of chemotherapy and immunotherapy, or targeted therapy and immunotherapy, so it's getting more complicated, and so no oncology professional is going to mind you getting some advice if they're drugs that you simply haven't heard of, or they're on a combination. If they're on a combination, it's difficult even in the oncology world to pull apart which drugs causing the side effect.
And I guess that adds to complexity hugely, doesn't it? But in terms of these wonderful drugs that you've described to us, but can cause worrying toxicities, do you know roughly what percentage of your patients would come through it and show a response and not have these side effects? I.e., we will always worry. You've explained that to us if they're on an immunotherapy, but actually, what percentage of patients, when we get a letter that says they're on immunotherapy, should we be really worried about toxicities with?
Yeah, so it's a really good question. So it depends what the immunotherapy drug is, and if it's a combination. So just to give you some ballparks for melanoma, so if I give combination immunotherapy, which is something called ipilimumab and nivolumab, so 2 drugs, 60% of patients will get a response, and that's some shrinkage. 20% will get a complete response, so their disease will completely disappear. But the flip side is 60% will respond, 60% will also have a grade 3 or 4 toxicity that will mean that they'll need to come into hospital at some point during that journey to be given IV steroids to manage it.
Wow. And just listening to the conversation we had last week about AOS admissions, or acute oncology admissions on treatment, being a not good prognostic sign. Is that true with immunotherapy, or can we take immunotherapy out of that group? Yeah. Okay.
Yeah, really good question. I would take immunotherapy out of that conversation as a rule, Elise. And actually, this is probably the important thing to bear in mind, is that if you have a nasty side effect from immunotherapy, you do better than patients who haven't had a nasty side effect, is number one. And then number 2 is, even given the high dose steroids to dampen down the immune response, you still do better than patients who haven't had an autoimmune side effect. So the fact that they've had this nasty side effect, people often say, well, you're not going to be able to re-challenge them anyway, so their prognosis is poor. But the reality is, if you've had a grade 3 or 4 diarrhea, hepatitis, pneumonitis, the chances are you don't need any more immunotherapy. And even if I don't give you any more immunotherapy, your immune system's probably going to take over the work without me giving any more drug, and your own T cells will continue that job in the background. So it's really important that people don't go, well, they've had a nasty side effect, therefore their prognosis is poor because you can't treat them. It's the flip side. They've had a nasty side effect, therefore the immune system's working, therefore they're likely to do well even without further treatment.
Oh, well, Thank you. I'm going to bring it to a close, but thank you ever so much for that answer. We've got another meeting next week on malignancy of unknown origin with some more information on the rapid diagnosis centres. A big thank you to both Rachel and Ricky for providing their time and some excellent knowledge to us today, as I know they've both got to go off to clinics now. And thank you from Fiona and the team at Cardiff University for supporting this. And like I say, or Charlotte said, please fill in your feedback, both for the speakers themselves, but also so we can continue to support these sessions without a fee going forward. Many thanks.
Thanks everyone for attending. Take care.